Great to see everyone here today to join us for our webinar on nutritional considerations with anti-obesity medications, evidence-based guidance. My name is Wendolyn Jones, and I'm the Executive Director here at IFANS. IFANS, or the Institute for the Advancement of Food and Nutrition Sciences, is a 501c3 organization that is grounded on our four core values: scientific integrity, transparency, collaboration, and public benefit. As an organization, we mobilize our members from government, industry, and academia to drive, fund, and lead actionable science. We catalyze the creation of scientific knowledge by funding external researchers and convening experts to support positive change. It is our collaborative and inclusive structure that allows members to bring forward the diverse perspectives across the entire food and beverage ecosystem. Now, because this is a webinar and we do want to try and make it interactive, we do want to take a moment and highlight how you can ask your questions. Know that we welcome your comments and questions. As this slide is showing on the right-hand side with your interface, there's an opportunity to type in comments and questions during our webinar today. Your comments and questions will not be visible to other attendees. They will only be visible to IFAN staff. And we will address comments and questions at the end of the webinar. So without further ado, allow me to introduce our guest speaker today, Dr. Jamie Almendarez from the University of Texas Southwestern Medical Center. Dr. Almendarez is an associate professor in the Department of Internal Medicine, as well as being a member of the Division of Endocrinology. He's originally from Trinidad and completed his medical training at the Royal College of Surgeons in Ireland. Following a residency as well in Ireland, he went on to complete fellowship work in endocrinology, metabolism, nutrition, and diabetes at the Mayo Clinic in Minnesota. Dr. Almendarez publishes frequently in medical and scientific journals, and he's involved in a number of professional organizations, including the Obesity Society, the Endocrine Society, the American Association of Clinical Endocrinologists, and the American Diabetes Association. He does actively see patients and is genuinely an expert in non-surgical weight management and medical care of patients following bariatric surgery. So without further ado, Dr. Almendarez.
Wonderful. Well, hello, everyone. Thanks so much for the invitation to present today on nutritional considerations for people taking anti-obesity medications. I'm Jamie Almendarez. I'm medical director for the Weight Wellness Program at UT Southwestern in Dallas. And I'm going to be talking to you today on a variety of things related to anti-obesity medications and nutrition. Here are my disclosures. So our objectives will be to kind of review the challenges of achieving clinically significant weight reduction, discuss mechanisms of action of anti-obesity medications with additional benefits, but also to outline the evidence-informed recommendations for nutrition in people using these therapies. It's not an obesity talk without a heat map, but all this to say that the obesity epidemic within the United States continues to escalate, where 1 in 10 people is now living with class 3 or severe obesity, and the problem's not getting better. The challenge is this is set to get even worse. Projections from this American Heart Association recent paper project that prevalence of obesity amongst adults in the United States will increase from about 43%, where it's at currently, to over 60% by the year 2050. And with this, we see a parallel epidemic growing in terms of diabetes, where more than 1 in 4 adults will be living with diabetes by that point also. So escalation in obesity, escalation in cardio-kidney metabolic complications of obesity as well. And I just want to kind of socialize the idea for those of you who may not be familiar with kind of the cardio-kidney metabolic syndrome, where we talk about increases in adipose tissue, adipose mass that may be unhealthy or dysfunctional in a way that then contributes towards cardiometabolic risk factors such as hypertension, hyperglycemia, and dyslipidemias that increase the risk of then developing subclinical cardio-kidney metabolic syndromes and then end organ damage or disease, such as atherosclerotic disease, heart failure, kidney disease, etc. And so there's a strong correlation between excess and dysfunctional adiposity and development of these risk factors that can then translate into disease, which is why we care about weight. It's not so much about the actual number on the scale, it's about the risk factors for developing complications and overall health. Some of the challenges are that our lifestyle factors that contribute towards accrual of excess and dysfunctional adiposity aren't great within the United States. These are examples of kind of challenges that society in general faces with regards to health behaviors such as diet, sleep, physical activity, and cigarette or tobacco use. And what we can see is that suboptimal dietary patterns is present in about half of society. And while that number or the proportion of people may not be increasing on average, by 2050, the number at risk is increasing quite dramatically. And so the question is, what are we going to do to support healthy weight, treatment of obesity and its complications as we look forward? When we look at the impact of lifestyle modification for achieving clinically significant weight reduction, the numbers are let's say, somewhat underwhelming when it comes to the challenge of treating obesity and maintaining weight reduction. What we see here on the left with regards to response to diet for weight reduction, be it a low-fat or low-carbohydrate diet, is that the maximal effect is typically seen around 6 months, with recurrence in body weight that occurs after that. On the right, we see response to physical activity, where there is a dose-response relationship in terms of the amount of work that's being done, here represented in minutes per week of moderate to vigorous physical activity. And we see that with greater expenditure of energy, we see greater reductions in weight, but also similar recurrence in body weight occurring after the 6-month time point. The challenge is that our bodies and our systems are very homeostatic and will drag us, for better or worse, kicking and screaming back to our highest ever fat mass. And there are a variety of mechanisms that contribute to this. This is kind of a dramatic oversimplification, demonstrating that there's upregulation in hunger and food reward, reductions in satiety, food restraint, and perception of the amount eaten when we are in a weight-reduced state. In addition, there's an increase in muscle efficiency and adaptive thermogenesis that supports, or rather, it allows us to do the same work with fewer calories, if you will. So we burn less. Beyond that, there are additional neurohormonal changes, such as modifications within within sympathetic nervous system, thyroid hormones, other adipokines like leptin, and other signals that will then predispose us to essentially eat more, burn fewer calories, and achieve weight recurrence, which is really not the goal of chronic obesity care. This is really to demonstrate the complexity of peripheral signals from a neurohormonal perspective that kind of center within the brain in as much as we understand them now. All that to say is that obesity is not a disease of willpower, and that there is a lot of intricate physiology that goes into energy homeostasis, weight reduction, maintenance of a weight-reduced state, and things that can go awry beyond, I wish my patients would just try harder to maintain weight loss. And I think the challenge is that many in the clinical space, unfortunately, either are unaware or choose to ignore the complex physiology, and unfortunately create stigmatizing experiences for people living with obesity who seek obesity care. And so the question is, how do we integrate the knowledge of this, plus nutrition and advanced therapies, including anti-obesity medications, into treating obesity in an effective way? Ideal therapies for treating obesity should decrease energy intake, which is primarily how anti-obesity medications work. They decrease hunger and induce satiety, thereby altering food cravings and preferences, what a lot of people on social media may call decreasing food noise. It would be great if we had a medication that would increase burning of calories through muscle or uncoupling or other means, but those are currently not yet available. There are questions as to whether the role of glucagon agonism in new and emerging therapies may fill this void, but we need to watch this space and see how things unfold. When we look at the weight reduction curves for people using anti-obesity medications, and I've divided these into, on the left, first generation anti-obesity medications, think phentermine, phentermine topiramate, bupropion, naltrexone, and liraglutide. And on the right, what we're calling second generation or next generation anti-obesity medications, where on average people lose 15% of their body weight. We see the curves with semaglutide 2.4 and tirzepatide, and what we see is that there's less of an uptick or recurrence in body weight occurring. We also see that it takes longer to achieve maximal effect, whereas with lifestyle interventions, we tend to see that at around 6 months, whereas here we tend to see kind of the nadir in terms of effect beyond 1 year towards that kind of 68 or 72-week time point. But of course, this is highly variable. When we talk with our patients about clinically significant weight reduction, it's important to frame things in terms of how much weight we need to lose in order to see the biologic or physiologic effect that we're hoping to see. Many patients will come into our practice saying that they think they need to lose 30 to 50% of their current body weight. The average BMI of the patient we see in our weight management program is about 40, average age is about 45. When we look at the magnitude of weight change that's needed to see improvements that patients and clinicians may want to see, such as blood glucose or changes in cholesterol or improvements in liver fat, a weight reduction of somewhere between 3 to 7 or up to 10% may be all that's needed. Much attention has been focused recently on achieving disease remission and decreasing the risk of hard endpoints such as cardiovascular events or 3-point MACE, such as cardiovascular mortality, non-fatal MI, and stroke. To achieve that, it looks like we need to exceed the 10% weight loss and shoot for 15% or greater weight reduction. The challenge is how can we do this consistently and maintain that? When we look at the lifestyle modification average of around 3 to 7%, that's not going to be adequate to achieve those goals. First generation anti-obesity medications, we're looking at up to 10% weight reduction. With newer anti-obesity medications, we're talking 15 to 22% in people without a history of type 2 diabetes. And really to consistently exceed this until this point, we've really had to rely upon bariatric surgery procedures, which while very effective, are not something that the average person wants to pursue, given that we have alternatives to treating obesity and its complications. When we look at the current landscape of FDA-approved anti-obesity medications, I'll start on the bottom right-hand corner. We have orlistat, which is a pancreatic or intestinal lipase inhibitor that causes malabsorption of about a third of dietary fat. It's something that can help with weight loss, but something not many patients enjoy taking given the risk for gastrointestinal misadventures and diarrhea, and the risk for malabsorption of fat-soluble and other vitamins. When we look at other treatments moving above that, phentermine and phentermine in combination topiramate, these are some of the most commonly prescribed oral anti-obesity medications which are available generically and quite inexpensively relative to other agents. It's something that many in primary care are very comfortable using and prescribing, but it may have additional challenges depending on comorbidities, cardiometabolic risk, and if you are treating women of reproductive age with reproductive potential, such as topiramate, which can cause birth defects. Bupropion naltrexone is something which is used for treating weight as well, either individually or as separate components, and is something which can really help with kind of cravings or reward or hedonic drive for consumption. Moving further down, the GLP-1 receptor agonist, liraglutide, and then most recently semaglutide, and then the dual GIP-GLP-1 receptor agonist, tirzepatide, have really kind of revolutionized or taken obesity treatment into the next space, where we're looking at impacting things at a brain-based level in terms of modifying appetite and satiety, also decreasing speed at which the stomach empties so people feel full with less for longer, but then also other peripheral targets such as adipocytes and other parts within the body. Within the pipeline, there are a host of other incretin and non-incretin based peptide therapies and other interventions which are in the works that will hopefully improve both the impact of weight reduction and disease-specific treatment of obesity. Those of us who work clinically within the obesity space are also no stranger to other medications off-label for treating obesity, such as metformin, non-liraglutide, non-semaglutide, GLP-1s, other stimulants, etc. And so this is a space in which one sometimes needs to be inventive in terms of how we use the resources that are available and appropriate for our patients to help them to achieve ultimately better health, not just a lower body weight. When we look at kind of the magnitude of weight change that we see, the green bar at the bottom is what one can expect with lifestyle modification versus the red bar at the top, which is the weight reduction expected with bariatric surgery in terms of sleeve gastrectomy and Roux-en-Y gastric bypass. We can see to the left the older generation of first generation anti-obesity medications really didn't do much to bridge this gap between lifestyle and bariatric surgery. Whereas with the advent of semaglutide and tirzepatide, we can see that we have encroached upon the bariatric surgery weight loss space in treating obesity. So it's great to have medical options for people who would prefer this and in whom these are most appropriate. We seem to be in a GLP-1 or bust environment when it comes to treating obesity, and I like to remind clinicians and my colleagues that older anti-obesity medications and those used off-label can also be effective. This is a recent retrospective review or analysis from Weintraub and colleagues at Cornell looking at their registry of patients for weight reduction, including older anti-obesity medications. There was a mean weight loss of 10.4% at more than 4 years. What's important to highlight is that 65% were taking 2 or more anti-obesity medications at that time, and the average number of medicines trialed was 4.3. So that means that people who are taking older anti-obesity medications often cycle through a variety of combinations. In those who maintain more than 10% of the weight loss, there were 92 unique combinations of medications, and interestingly, 13% were on metformin monotherapy, and metformin is not approved for weight reduction. About 10% were on combinations of metformin, phentermine, and topiramate, likely because of the efficacy of phentermine and topiramate in combination for decreasing weight. But what's important to highlight as well is that people who were more likely to achieve 10% weight reduction had more clinic visits. So it's important not just to prescribe medications, but to see patients back frequently to provide iterative lifestyle, including nutrition modification to support weight reduction, maintaining a weight reduced state, and treating the cardiometabolic complications of obesity that we're focused in on. To talk a bit about semaglutide, it's a once weekly GLP-1 injection that's available in 5 different doses. Patients are typically started at the lowest 2.25 milligram dose, and it's titrated every 4 weeks or so according to symptoms and dose response. The average weight reduction at 68 weeks was about 15% relative to 2.4% in placebo. I think it's helpful to look at categorical weight loss outcomes, what proportion of people achieved, for example, 5% and 20% weight loss. We can see that in the semaglutide group, over 85% of people achieved 5% weight loss or greater, and about a third of people achieved 20% weight loss or greater. When we look at tirzepatide, which is approved for treating obesity at 5, 10, 15 milligram doses, we can see that at the 15 milligram dose, the average weight loss for those in the treatment group was about 21% relative to 3% in placebo, with more than 90% of subjects achieving more than a 5% weight reduction and over 55% achieving more than a 20% weight loss with treatment. Question is, well, why are these so helpful for weight loss relative to other medications? And it's likely due to their mechanisms of action. Is there an advantage to the addition of GIP to GLP-1? There are many questions on which there's much speculation and hopefully some emerging answers as we have more and more multi-receptor agonist agents to help us understand and differentiate which treatment and which option is the best for our patient. When we look specifically at the different mechanisms of action, for example, with GLP-1, we know that there is a decrease in food intake with GLP-1 agonism. There is, in response to hyperglycemia, an increase in insulin secretion, a reduction or suppression in glucagon secretion, and delays or changes in gastric emptying. When we look at the impact of GIP, we can see that there is a reduction in food intake, but also a reduction in nausea. There's an improvement in adipose insulin sensitivity, thoughts about altered nutrient metabolism or increased lipolysis within the pancreas is increased insulin secretion, but also increase in glucagon secretion. There are thoughts that the coagonism with tirzepatide of GIP and GLP-1 may improve the tolerability by decreasing nausea with GIP that allows us to then lean in more on the GLP-1 for appetite suppression and improvements in body weight. And as we move forward, these are phase 2 data from retatrutide, which is a triple agonist for GIP, glucagon, and GLP-1. These are 48-week outcomes with respect to body weight, and what we can see as a response on average of about 24% weight reduction in just 48 weeks. If we think back to tirzepatide, those results we talked about 21%, were at 72 weeks. When we look at the categorical weight loss in the body weight reduction targets on the right, we can see that 100% of people were achieving more than 5% weight reduction. About 63 to 70% of people were achieving more than a 20% weight loss, and this is just at 48 weeks. So what we see is a kind of a newer generation of multi-receptor agonist anti-obesity or obesity medications that are achieving very significant weight reduction in a short period of time. But as with any treatment for obesity, be it dietary modification, bariatric surgery, or pharmacotherapy, there is a lot of heterogeneity or variability in terms of response. And what we can see here is essentially a kind of a normal distribution of categorical weight loss response. And so if we look on the left with liraglutide, and then we see the vertical dashed line, those to the left of the line are those who gained weight within the treatment group versus those who lost weight to the right. And we can see that there is a shift as we transition to semaglutide and tirzepatide in terms of the proportion of people losing greater magnitudes of weight with therapy. And so this can be a good way to kind of center ourselves that not everybody loses the mean amount of weight, and there's a lot of variability in terms of weight reduction response, which means that there will be a lot of variability in terms of what somebody may need from a nutrition support perspective as we progress through treatment. Beyond changes in body weight, which I think is a very kind of crude way of looking at obesity treatment, I think it should be important, to look at changes in body composition. What are we made of? There's been so much in the news within the last year on so-called quality of weight loss, or how much lean mass we lose relative to adipose or fat mass. This is a recent paper looking at reductions or changes in fat mass and fat-free mass with different interventions for treating obesity. And what we see here with respect to fat-free mass is reductions somewhere in the region of 25 to 39% with incretin-based therapies for treating obesity. What I would like to highlight, though, is that overall, the reduction in fat-free mass and specifically skeletal muscle mass, which is not represented here, just fat-free mass, is usually relatively small to the magnitude of reduction in fat mass. And when you look at it overall, someone is left with a better overall body composition with regards to total body fat percentage. But even beyond that, it's important to look at, well, where is that fat distributed? We know that there is a much stronger association with ectopic or visceral fat and adverse health or cardiometabolic outcomes relative to total body fat. So it's important for us to contextualize for our patients that it's not just about weight loss, it's about achieving a healthier body composition, but also where we store that is also important. And we need to contextualize how we communicate that to patients and how we translate that into clinical practice in our offices. When we look at changes in body composition with weight loss, again, we're kind of looking at kind of a baseline on the left before weight loss, and then after a variety of interventions. First, we have diet alone, then diet plus protein, and diet plus exercise. We can see that if we are increasing protein, there is a relative kind of, let's say, increase overall in body composition at the end of skeletal muscle mass, in spite of likely losing some as part of the process. The incorporation of exercise also supports maintenance of lean mass with weight reduction. And so I think it's important for us to look at, for people who are taking anti-obesity medication therapies that decrease energy intake primarily, how do we support them with adequate recommendations for protein intake to support maintenance of lean mass, but also incorporate in other lifestyle modifications such as resistance training that also will support preservation of lean mass as part of a health journey. With that, in collaboration with Eli Lilly, a relatively large group of us put together some nutritional considerations with anti-obesity medications to help guide our colleagues and clinicians with regards to what should we do. Many people who are being prescribed anti-obesity medications may be receiving them from clinicians who may not be or may not have additional training in nutrition and metabolism and may not feel equipped to have the information to give to patients. They may not have resources such as registered dietitians, and so we thought it would be important to help patients to do that. Currently, there were no evidence-based reviews or recommendations available to discuss what to do from a nutrition perspective in those taking highly effective anti-obesity medications or next-generation anti-obesity medications with an average weight reduction of 15% or greater. And what we hope to do was to provide practical nutrition advice and tips to support clinicians who are treating obesity using these new agents, given the high spread use and the demand from patients for using these therapies, which are very effective and have been quite game-changing. I think it's always important to kind of empower our colleagues to provide kind of stigma and bias-free care and creating kind of a healthy conversation with their patients around weight, starting conversations around weight with what we call the 5 A's approach, where we're first asking permission, assessing, advising, agreeing, and then assisting with regards to how we're going to approach treating obesity and partnering with patients with shared decision making to provide them with tools to achieve not just that lower body weight, but also to make sure that they are achieving better health. It's also important in the assist process to make sure that we are deciding, are additional services needed for our patients to support them on this journey? Do they need to see, for example, a registered dietitian or clinical psychologist to support other aspects of their care? Would they benefit from seeing somebody in physical medicine rehabilitation to address their chronic joint pain or to provide individualized physical activity programs to support better health and preservation of lean mass as part of this journey in conjunction with nutrition recommendations? This is kind of an overview from an infographic within the paper that I like, which kind of provides a rough structure and demonstrates kind of the cyclical or chronic nature of management, where we start with nutrition assessment, talk about what to advise in terms of kind of macronutrient, fluid, and other intakes, but then also monitoring treatment response, specifically with respect to gastrointestinal side effects, which can be a limiting factor in patients tolerating and continuing treatment with these evidence-based therapies. We're going to start by talking about the importance of assessing baseline dietary patterns, preferences, but also the medical history. There are a multitude of risk factors for malnutrition, obesity being one of them. Making sure that we understand our patients' surgical history. Many patients who have undergone bariatric surgery previously may have experienced post-bariatric weight recurrence and may be seeking care for their weight and complications. It's important to identify patients who may be at risk for malnutrition because of anatomical or other changes within the gastrointestinal tract, or who may be more likely to experience gastrointestinal adverse events from medications based on their anatomy. Those who are of advanced or older age who may have additional challenges, including dentition, including access to food, including starting off with an adverse body composition or lower muscle mass because of sarcopenia of aging. It's important to contextualize, are we going to improve their health or put them at risk by modifying their intake in a way that may not support optimal health? Assessing for chronic comorbid diseases such as chronic kidney disease, heart failure, gastrointestinal tract disease such as inflammatory bowel or celiac disease. Assessing for disordered eating behaviors, mood disorders, and substance use in patients who are going to start treatment can be very important. Assessing baseline gastrointestinal symptoms, making sure that patients receive adequate evaluation and treatment of these before starting care to ensure that we do not exacerbate symptoms or cause additional distress or health problems by ignoring these. Identifying people who may be experiencing unintended weight loss before starting these medications to ensure that they are up to date, for example, with age and risk appropriate cancer screenings as part of their care, given that obesity in itself is a risk factor for many cancers. Identifying people who may have underlying food insecurity or monotonous type diets, which may predispose them to a lack of balance or low quality intake. And then, as mentioned previously, poor dentition, where food textures and variety may be important for getting balanced nutrition. We'll want to look at other options or solutions. Depending on what is found in this, deciding when to refer to a registered dietitian for additional assessment, follow-up, and recommendations is an important part of nutrition care with obesity medications. When looking at considerations, there are several different ways to look at calorie intake. It's generally considered safe for women to be consuming in the region of 12 to 1500 kilocalories per day, for men between 15 to 1800. For those taking very low calorie diets, those are considered to be less than 800 kilocalories per day. These should really only be used under medical supervision. And it's important to note that energy intake should be adjusted or may need to be adjusted depending on the magnitude or the change or trajectory of weight and when the target weight is achieved to make sure that we are achieving the right balance for our patients. For those consuming for those on anti-obesity medications, working out what the correct volume of fluids is will depend on their underlying health and cardiac and kidney and hepatic status as well. In general, we recommend around 2 to 3 liters of fluid per day in order to prevent dehydration and constipation that can be seen with these medications. We encourage people to sip rather than drink quickly to avoid feeling bloated or nauseated. So sip, don't chug is something that we often remind our patients to do when it comes to consuming their fluid. We recommend consumption of water or low-calorie beverages or non-nutrient dense beverages such as low-fat dairy or low-fat alternative dairy products. We advise patients to limit things such as sugar-sweetened beverages or those that can exacerbate symptoms associated with GLP-1 therapy use, such as alcohol, carbonated beverages, or caffeine that could lead to additional dehydration. When we talk about, well, how do we help patients to structure meal planning, it's important, I think, to focus in on balance. For so many of our patients who may have lived with obesity for years, if not decades, they're accustomed to very restrictive dietary patterns where they're focused in on what they're cutting out, what they can't eat, when in the day they can or can't eat. And I think it's important to reframe this, that with tools that are helping us or taking the fight out of obesity by inducing satiety, decreasing appetite, cravings, and making us feel fuller with less and longer, what we want to do instead is focus in on what we should be eating in the form of balance. Using a plate method such as this is a nice way of kind of simplifying conceptually what people could be doing. For example, 50% of their plate with non-starchy vegetables or kind of low carbohydrate fruits or berries, about a quarter of the plate being protein. Here, tofu is used as an example, but animal protein, depending on your persuasion, is fine also, and 25% whole grains or starches. Discuss kind of what fluids and how to eat with meals. For many people, managing how much volume they drink and when they drink can be helpful for managing some of their symptoms of bloating, especially during the dose titration phase of medications, and considering dessert options, because we're all human, depending on what kind of calorie intake and balance and symptoms patients are having, can be helpful to make people feel normal and balanced as part of what should be a long-term health journey. We talk about prioritizing protein intake for people who are on weight loss journeys, be it through bariatric surgery or anti-obesity medication therapies. There are kind of broad guidelines for protein consumption depending on age, kidney function, etc. So there's quite a span here of between 0.8 to 2 kilograms per day of usually actual body weight rather than ideal. But you could use ideal, but it will just bring in a lower target. For many, the simplified recommendation of aiming for around 60 grams or more of protein per day can be a helpful way to keep it simple. You can choose to do more than 1.5 grams per kilo body weight per day in select individuals, depending on what their needs are. We encourage patients to find opportunities to eat protein throughout the day and to pace it out at every meal so that they're not trying to consume everything all at once, because depending on their gastrointestinal side effect profile and dose titration, this may make them not feel well. We encourage people to prioritize protein at the meal, to start with it, and then to kind of go through the rest of their constituents on their plate after they've gotten their protein in, for a variety of reasons, including making sure they get it in before they feel full. There's lots of different ways that we can incorporate protein into our plate and into our foods, including looking at eggs, poultry, and non-animal sources, including lentils and peas, to ensure that all people's food preferences are acknowledged as we look towards balancing meals and nutrition. When it comes to carbohydrates, kind of an acceptable macronutrient distribution for carb intake is around 45 to 65% of energy intake, which translates into about 135 to just under 300 grams for a 1200 to 1800 calorie diet for men and women, based on what we've discussed. For those who are doing a carbohydrate restricted pattern, which appears to be kind of the most common that people will talk about, which varies in execution, is somewhere between 50 to 150 grams per day, which may provide health benefits, particularly for our patients who may be living with diabetes. Severe carbohydrate restriction is not necessary as part of this, but it's something, unfortunately, that is very popularized in social media and other platforms for people taking anti-obesity medications and for those trying to discontinue anti-obesity medications. Yet we don't have good evidence to support that this is a beneficial or preferential pattern for patients that will infer better weight maintenance or better health outcomes. Considering non-starchy vegetables, fruits, and grains as part of the carbohydrate intake, aiming for lower glycemic, higher fiber options is also helpful. Examples of these include things such as cucumbers, cauliflower, berries, brown rice, and lentils. When we look at fat, typical or acceptable macronutrient intake of fat is around 20 to 35% of overall energy intake, which equates to somewhere between 25 to 70 grams for someone on a weight-reducing 1200 to 1800 kilocalorie diet per day. A low-fat diet is anything that's 10 to 30% or lower kind of calories from fat. Again, severe restriction is not necessary. We do recommend that patients choose healthier, unsaturated, poly and monounsaturated fats when they are ingesting fats, and limit the intake of saturated and trans fats, including tropical oils. We advise against consuming high-fat foods to minimize gastrointestinal issues, as this can often make people feel fuller quicker or can exacerbate reflux and other symptoms that patients may be experiencing. There are lots of different ways to get fat in the diet that's not oil or butters, as we may think, including avocado, tahini, pumpkin seeds, dairy products, and chia seeds. When we look at facilitating fiber in the diet, this can be very helpful for a variety of health reasons beyond weight reduction and cardiometabolic health. It can also help to mitigate some of the gastrointestinal issues that patients may experience when taking incretin-based therapies, including constipation and or diarrhea. It's recommended that women consume somewhere between 20 to 25 grams per day and men 30 to 38, which is around 14 grams or more per 1,000 calories per day. Fiber can be found in many of the foods we've already discussed, including the whole grains and non-starchy vegetables and fruit, but it's important to encourage patients to select options that contain fiber. And examples of this include those we've discussed before, such as broccoli, brown rice, almonds, etc. When it comes to micronutrients, it's important to focus in on balance. We're often talking about eating the rainbow, and there are many foods that are rich in commonly deficient micronutrients, for example, such as green leafy vegetables and fruit, milk and dairy, meat, seafood, and whole grains and fortified cereals that can be helpful. When people take a complete multivitamin, that is associated with a reduced risk of nutritional deficiencies. However, it's important to note that obesity in and of itself is a risk factor for micronutrient deficiencies, and taking a complete multivitamin may not be sufficient in order to correct pre-existing deficiencies in patients who may have existing deficiencies and who are then starting a low-calorie or energy-reduced diet. It's important to assess the baseline kind of gastrointestinal health of our patients to troubleshoot any existing things that are there so that we can route them for appropriate evaluation and treatment if they have pre-existing gastroesophageal reflux or symptoms of peptic ulcer disease, for example, or existing constipation. It would be helpful to identify these people up front so that we can be proactive both with assessment and treatment so that these do not get worse with treatment and do not limit access to evidence-based care. In general, we recommend things such as diet modification of eating smaller nutrient-rich meals, limiting high-fat or spicy foods or alcohol-containing or carbonated beverages, having patients partner with their clinicians on reducing doses, slower escalation, stopping or changing to a different anti-obesity medication can be helpful in mitigating side effects. Also considering over-the-counter therapies for things such as heartburn, reflux, constipation, and making sure that people are meeting their macro and micronutrient needs, and then identifying who may need short-term supplementation, be it with using protein shakes and taking a break from solid foods, for example, until their stomach settles down. There's a nice article by Wharton and colleagues, which kind of is called the 3 E's, which goes through kind of making sure that you educate and explain to your patients the mechanism of action of how GLP-1s work and what foods and things may exacerbate, making sure that there is appropriate dose escalation or adjustment based on patients' symptoms, making sure that we escalate slowly in those who may be at risk for things such as dehydration, and then also effective management of the GI side effects, which includes appropriate assessment, pauses in treatment, working out how best to treat things such as vomiting, gastroesophageal reflux, etc., and working out how to best serve the needs of our patients. I think too often I'll hear in clinic that patients may have sought care elsewhere and will have been started on an agent that is just automatically titrated every 4 weeks without anyone checking in with them. How they're doing, are they having side effects, how much weight they're losing, are they meeting their nutrition and exercise goals. So it's important for us to have more holistic care when it comes to treating obesity. One of the challenges when it comes to treating obesity is, and these are granted older data, is that those who start an obesity treatment seldom continue it for very long. If we look at the vertical green line towards the left, these are people who are initiated on therapy, and if we follow it out, the green line are people who are continued on anti-obesity medication therapy at 12 months. Granted, these are data up to 2018, so we're in a different time and landscape now. When we look at a recent publication in obesity from March of this year, we can see that continuation or adherence rates for semaglutide for obesity at 12 months is around 40%, which doesn't look great, but relative to the other anti-obesity medications, including orlistat, phentermine, topiramate, etc., we can see that it's significantly greater. The odds that someone continues semaglutide at 1 year was more than 4 times that than somebody who was taking phentermine, topiramate, for example. So while these adherence rates may look poor, they're significantly higher for semaglutide than other older anti-obesity medication therapies. But it's important for us to contextualize, are patients taking their medications? How long will they be taking them for? And what's our plan when patients are off drug? When we look at persistence, we see from this Blue Cross Blue Shield data for anti-obesity medication therapy, specifically GLP-1s, that less than half of those who were prescribed stay on the medications for 12 weeks or more. Those who receive prescriptions from endocrinologists or obesity specialists were more likely to continue the medications. It didn't matter about gender. Those who had the highest kind of social barriers were least likely to continue medication, and those who were aged 18 to 34 are less likely to continue drug. And information such as this can help to guide clinicians on who should they be asking about additional factors and who should they be following up with more regularly to ensure adherence to treatment that is indicated for them. These are highly effective treatments, but like many medical therapies, are only effective when you take them. And what we see here from the Step 1 extension study on the left and SURMOUNT-4 on the right is that these medications work very well to control body weight, but with cessation of therapy, on average, people regain about 2/3 of the lost weight. It's not that these medications are not effective, it's that they're effective when they're taken. And given what we discussed with regards to long-term continuation, you can see that there may be problems or opportunities within the market for providing patients who are off drug with nutrition support that helps them to maintain their weight reduction and hopefully improvements in their cardiometabolic health profiles. Because we know, and these are data from 4-year data from the Cardiovascular Select Outcomes trial, that with semaglutide 2.4, for example, that patients will maintain their weight reduction out to 4 years and likely beyond with continued therapy. And the question is, in this phase, what is the role of nutrition and other care? As we evolve in the space for anti-obesity medication therapies with many other gut-derived peptide targets and others beyond, there will be opportunities for tailoring our therapies, not just for magnitude of weight reduction, but for disease-specific states in which we have an evidence base for therapeutic action. With that, we'll need to work out how do we integrate nutrition into this. Some additional considerations in the space in terms of what we need to factor in terms of opportunities for research and exploration are specific dietary recommendations for those in the active weight loss and titration phase versus those in the maintenance phase on drug. Guidance of rate of weight loss and nutrition support in terms of, does a person who's losing 2 pounds per week need something different to somebody who's losing half a pound? What's acceptable, what isn't? Should we recommend broadly micronutrient supplementation or fortification in patients who are taking these treatments? And how does that vary, for example, if they have a bariatric surgery history? Are there specific recommendations we should have for someone with a bariatric history, given that about 250,000 people in the US are undergoing primary bariatric procedures per year, and obesity is a chronic and complex disease? When it comes to people discontinuing GLP-1 agents for whatever reason, we see a variety of challenges based on access, based on pricing, based on coverage that unfortunately do not support long-term chronic use of GLP-1s for managing obesity as effective as they are. And the question is, what kind of nutrition interventions should be recommended? But if patients do need to come off drug, is this something that should be tapered? And how do we incorporate or layer in nutrition interventions as we do that too? But of course, one of the other frontiers is how do we integrate technology, AI, wearables, and other devices into anti-obesity medication, nutrition, and obesity care, one, in general, and two, specifically for those on drug and for those who may be coming off or want to come off of medication therapies. To kind of just wrap this up and summarize, anti-obesity medication use does significantly impact food intake through a variety of mechanisms, including changes in appetite, hunger, and cravings. People who are living with obesity may be at higher risk for malnutrition in general, and malnutrition risk may be higher based on someone's baseline health and or whether or not they've had bariatric surgery. In those who are being started on anti-obesity medications, clinicians need to perform nutritional assessments and counsel patients on the importance of balanced diets. And we need to focus in on providing patients with recommendations about dietary quality and nutrient-dense foods to prevent deficiencies, emphasize the importance of things such as hydration, healthy balanced eating, and the integration of physical activity like resistance training to attenuate loss of lean mass, and also making sure that we are referring patients to registered dietitians where appropriate. This is kind of a summary of the recommendations from an energy intake perspective: protein, carbohydrate, fat, and fiber from the article, just to kind of give you a rough kind of reminder of the balance that we are trying to focus on and not restriction. And I think that's really what has made the use of GLP-1s and anti-obesity medications so game-changing, as we've moved away from a restrictive pattern more towards one of balance for people living with obesity. And just to kind of bring this home for people who we are treating with anti-obesity medications for obesity as a chronic disease, to make sure we do adequate baseline assessments of medical history, medications, behavioral and other kind of environmental challenges, and that we have an integrated weight and complication management, nutrition, activity, and behavioral plan, whether they are going through pharmacotherapy, bariatric surgery, which should be part of this integrated plan, but knowing that patients will likely in their lifetime cycle between a variety of different interventions, including procedures and pharmacotherapy, particularly those living with severe obesity. So with that, I'd like to thank you for the opportunity to talk today, and I'd be happy to take questions.